All right, let's go ahead and get started. Welcome, everybody. Thank you all for being here. My name is Gene Guidry. I am the, let me get this out of the way, the ULI Programs Chair for ULI Louisiana. And I'm very excited to be able to kick off our very first debut content hour series. We're going to be trying to do these every Thursday at 4:30. And our first one is entitled Healthcare and Sustainable Communities with EXCELth, with the wonderful Dr. Green and Dr. Webb. Most of you know, I would think, about ULI. We are a membership-driven organization. We are national and international, and ULI is mainly about proper land use and membership driven. It's a multidisciplinary organization, lots of different professions that we touch: architects, engineers, attorneys, public officials. It's a diverse crowd. And we have a couple of upcoming events. If you want to go back, Nicole, I'll touch on those. Well, as part of our content hour series, like I said, this one is our first one. Our next one is with Wagner and Ball on a water retention project. We're also going to look at the Odeon in the South Market District. And December 3rd is New Orleans restaurant industry with Nina Compton and of Compare Le Pen and Bywater American Bistro. And then on the 10th, we're going to do the World War II Museum. And then we have our also a real estate breakfast with New Orleans Business Alliance and a new member orientation. So please check them out. All of our upcoming events are created here locally with the local programs committee in New Orleans for Louisiana. We also wanted to just briefly talk on technical assistance panels. This is something that ULI National provides a service. And basically what you can do is, if you have a difficult land use or development or redevelopment challenge, you can connect with ULI National and create a technical assistance panel, and us on the local chapter will help assist this. And we bring in a group of experts to hear about what the issue is and then provide guidance. And it's a really wonderful program, and we try to do a couple of them a year. So we just want to put out the word that this is a really great service that ULI provides. It's often called a TAP. So yeah, we just wanted to bring it up that this is a great opportunity if you need to use it. And then, of course, ULI is membership driven and sponsorship driven. And we like to thank our annual sponsors, our Diamond, Emerald, and Ruby sponsors. So thank you to all. And now I'm going to introduce Dr. Webb, and then Dr. Webb is going to introduce Dr. Green, and then I'm going to get off here so that they can do their thing. Dr. Webb is the Associate Clinical Director and COO at EXCELth. She's responsible for day-to-day operations of healthcare centers and facilities. Dr. Webb serves on staff at the Minority Health and Health Disparities Research Center of Dillard University and LSU. She's a former director of health for the city of New Orleans. She served under 2 mayors and was the first African-American and first non-physical director of health for the city of New Orleans. She's a former commissioned officer of the U.S. Public Health Service. And she's also the president-elect of YWCA. And I could go on for a while. Her bio is a lot longer than this, but I'm keeping it short. So anyway, Dr. Webb, I'll pass it on to you.
Okay, thank you very much, Gene. It's my pleasure to be here with you all today. And it's my privilege to introduce Dr. Green, my colleague. Dr. Green works here with us at EXCELth. She is the Director of Quality Improvement, Epidemiology and Risk Management at our facility. She basically oversees our quality improvement program, which includes risk assessment, policy development, and strategic planning, monitoring, and evaluation. Dr. Green has a very impressive career in terms of academics. She holds a Bachelor of Science in Chemistry from Tuskegee University, a Master of Public Health and Epidemiology, a Doctor of Science focusing on chronic disease and health disparities from Tulane University School of Public Health and Tropical Medicine. She is a researcher focusing on hepatitis C and health disparities. My pleasure. Dr. Green.
Dr. Green, you're muted.
Yeah, I think you're muted.
Thank you, Dr. Webb, for that introduction. And I'm appreciative of being asked to speak today. So just let us know when you're ready to start, and I'll take the screen from Nicole.
Go for it.
Gotcha. Okay. Okay, can I get a confirmation that you can actually see the presentation mode?
Yes.
Great, okay.
Okay. All righty. Dr. Green and I are going to essentially tag team this presentation. We understand that we don't have a really large audience on today. And so we've kind of are going to kind of modify things to whereby we can make this a less formal presentation and entertain questions and maybe make it somewhat like a dialogue. So feel free to do that, to interrupt us, to ask questions and so on and so forth, and we'll accommodate your requests. We are going to talk today about EXCELth Incorporated. We are a community-based organization that provides healthcare services here in New Orleans. We have been here in New Orleans since 1991, serving communities in surrounding parishes. And we are happy to say that we're going to be making 31 years old on next year. So we have been around for a while. We are a part of a network of healthcare facilities that exist in this country. These health centers are sometimes referred to as federally qualified health centers. And I'll spend a little time talking to you about what a federally qualified health center is, since a lot of people really don't know what they are. But again, they've been around for 55 years in this country, servicing primarily as a safety net for underserved populations. Community health centers exist in the United States, which includes the District of Columbia, Puerto Rico, the Virgin Islands, and the Pacific Basin. Services are provided throughout this country, and those services are done and provided by way of about 1,400 organizations that exist throughout the country. And those 1,400 organizations represent about 13,000 service delivery sites. Those sites provide services to about 30 million people a year. So this is a significant part of the healthcare delivery system of this country. Over the last 20 years, community health centers have really advanced in terms of size and distribution across the country. There are more than 252,000 nationally healthcare providers that operate in these healthcare centers and providing services throughout the country. Here in Louisiana, we are part of a network because again, these centers are, they're from the federal level and then to the state and local levels. But in the state of Louisiana, health centers, we operate here, and we have a total of about 36 health centers that comprise about 260 individual sites. And these combined sites provide about care to 500,000 people on an annual basis. So I'm going to kind of focus in on more specifically on EXCELth. That gives you a little bit of a global view of where we fit in the larger umbrella of service delivery. So Dr. Green, would you advance the slide, please? Here in New Orleans, we operate 5 sites, and our sites are located in strategic locations. We operate a health center in Algiers on the West Bank. We also have a dental center on the West Bank as well as in Algiers. We operate a behavioral health center in Baton Rouge, Louisiana, and we also have centers in Gentilly as well as New Orleans East. This service delivery map kind of shows, it's very busy and all, but it shows where our sites are located, and it shows where people come from in terms of the areas where they come from. So we service not only Orleans Parish, but we do get patients that come from Jefferson Parish, the East and West Bank of the river. As well as we do have patients that come to us from Slidell, as well as St. Bernard Parish. In Baton Rouge, our services there, since they are primarily behavioral health services, the service area is a little less busy because we do a very specialized service there, and it's primarily people that are in East Baton Rouge parishes that we provide services to. So in terms of the locations of our health centers, again, we service a population of usually people that are underinsured and uninsured, at-risk populations. This is what the mission of community health centers is. That was initiated back when they started some 55 years ago. And this is just one of the things that we do in terms of planning health centers, that we want to make sure that these health centers are located in communities where they are on bus routes where people can easily access them, and that they are conveniently located to provide services to the communities that they serve. So if you look at community health centers and this FQHC designation that we have, I wanted to just mention a couple of things that distinguishes that designation for community health centers. And these are the centers that serve people throughout this country, that they receive federal funding. And this funding comes from the 330 Public Health Service Act. There has enhanced reimbursement because, again, we do provide services to individuals regardless of their insurance status. As indicated with the sliding fee scale, we will serve everybody regardless of your ability to pay. The enhanced reimbursement that we receive for our services allows us to provide services for persons regardless of their ability to pay. Community health centers are distinguished by the fact that our governing boards have to be 51% consumer boards, meaning that over half of our board of directors are our patients as well. And this gives us a very unique perspective in that persons who are receiving services at our health centers are also the people who are governing and directing them. Services provided, and this is not an exhaustive list, but just to give you an idea, preventive health services, primary health care, dental, mental health, and substance abuse. We do OB/GYN, podiatry, other specialty services by contractual linkages and support services. Because we're addressing the needs of many people who are uninsured and underinsured, we deal with a population that present with a disproportionate impact and burden of disease in many instances. So we are dealing with many health disparities and health inequities within our population, as well as the social determinants of health, And I just did a image here of the social determinants. And again, I realize that our group may or may not be familiar with the social determinants, but social determinants of health, and this is as defined by the World Health Organization, are conditions in which people are born in, they live in, and they exist in all their lives. These are these structural areas within communities that impact upon people's lives. And so our patients are people who are confronted with many of these social determinants of health. So in addition to meeting their healthcare needs, we also have to consider what other areas in their lives are being impacted. And you'll see, I can just read a few of them off. I don't want to stretch this out, but poverty is a big one. In terms of racism is another one. Social exclusion is another one. Education and chronic stress. All of these are social determinants of health. And they basically, impact our population, and we have to be prepared to address them, again, as we basically work with people around their healthcare needs.
Curious if you see any additional disparities specific to New Orleans that other regions or other states may not be dealing with?
So I would say that we essentially, again, we are similar to other, I would say, providers that are in the southern region of the country. So we see people that have high blood pressure, with diabetes, with major, those are two major chronic conditions that we constantly deal with. Hypertension, obesity is another one that we're dealing with. We tend to have more obese patients in the southern part of the United States. So again, compared to maybe our northern counterparts, we tend to have people that are more obese in the South. I would say here in New Orleans, we are really dealing with a disproportionate number of people within the city that represent some of these poor chronic conditions. Some of it having to do with our dietary habits here, in terms of some of it having to do with quality of life, and some of it having to do with these social determinants of health that again, people have to live with and that they're confronted with. Such as food deserts. We have people here in New Orleans that essentially are living on what is defined as a food desert. So I would say that we basically see those conditions that exist in populations that are in somewhat that have issues of economic prosperity issues and poverty issues, and that it would be similar to other communities in the country that have these same problems.
Dr. Shelia, I have a question. Also, as it relates to like two different types of population, one is undocumented and the other one is the travelers, nomads, which are younger but have a lot of health issues. Is that something that you guys see coming to your facilities?
Oh, that's Miriam, huh? How
yes.
You doing?
Hi, Dr. Shelia. How are you?
Good to see you. Yeah.
Very, very nice to see you again.
Yeah. Okay. So, again, in terms of, I want to make sure I understood your question. You said that you want to know if we're dealing with, I guess, a younger population and what they're presenting with it. Was that the question?
Yeah, like I don't know what is the proper terminology, but what people refer to the gutter punks that you see a lot in the French Quarter that are by being nomads, don't have a zip code or where do they go? And obviously they have a very large host of issues, health issues, whether it is behavioral or physical, right? And also underdocumented illegal aliens that for fear of not being reported will have a lot of issues with diabetes and hypertension and not have it controlled, right?
Exactly. So yes, I hear your question. And so we serve a diverse population, and Dr. Green is going to kind of talk about that a little bit further in the presentation. But we do see a lot of the immigrant population, because that's one of the things about community health centers, is that we will see persons regardless of their immigration status. Again, that's one of those distinguishing characteristics that we have. In terms of people sometimes referred to as street people, we will see them depending upon where we are, where they are. Occasionally we'll have people that will come to us again from many, many different walks of life. As you mentioned, Miriam, that what we find is that that we see, some populations that essentially have health issues that again, that's related to, again, the cultural habits of that group, the quality of life, and in terms of how they live, as well as dealing with all the social determinants of health. So again, in terms of, we do see, Hispanic population, we've got a growing Hispanic population here. And what we find is that the more recent that the population has immigrated, and again, depending upon where they come from, that you basically, see the conditions of health disparate conditions emerge over time as they basically adapt the lifestyles that they are, in. Some of these individuals that we see, depending upon where they come from, they've actually gotten very good health care in their countries and all.
Yeah.
Some of them have not gotten good health care. So we see that as well. The other one big need that we're addressing that we see is the need for dental care. We have a lot of patients that come to us, and these are local patients as well as people who've recently moved here that have really tremendously unmet dental needs. Okay, Dr. Green.
Okay. So now Dr. Webb gave a great, global view of who we are as a federally qualified health center, also a community health center, and then the issues that our patients deal with, or the issues that are affecting our patients. And so what I'm going to do now is speak to how do we consider all of these constructs and the health disparities and health inequity issues, and how do we care for our patients, considering all that our patients may bring to the clinic on any given day. And so EXCELth operates under what we call a patient-centered medical home model. And what that is essentially is it's a care delivery model whereby patient treatment is coordinated through their primary care provider, their primary care physician, to ensure they receive the necessary care when they need it in a manner in which they can understand. So to Miriam's question about, we want to structure it so those patients, whether they are gutter punks or or homeless or immigrants, that in a manner that is sensitive to whatever their needs are, what are they bringing to the door. And so that's really important in operating as a patient-centered medical home. Additionally, I would say that patient-centered medical homes, they have emerged as a promising solution to addressing the significant fragmentation, poor quality, and high cost that afflicts the U.S. healthcare system. The medical home model includes core components of primary care and patient-centered care, recent interventions and practice redesign, health information technology, and changes the way practices are paid and providers are paid, speaking to the whole sustainability concept. And so as you see on this slide, what I do offer here is, EXCELth is a patient, we're actually a nationally recognized patient-centered medical home by NCQA, and that's the National Committee for Quality Assurance. And then to the right of the screen, I just give you a visual of exactly what a patient-centered medical home is. And it is like a neighborhood, as you can see here. And then within the neighborhood, the patient is at the center. But what happens around the patient? We are coordinating care. We provide high quality care, and we're committed to doing that. we're ensuring that the patient, all of these services and resources are accessible to the patients, and that everything is comprehensive. And so then outside of this home, if you will, you would notice here are some of the services. You have social services, you have access to nutritionists, pharmacy. Pharmacists are either on campus or through our 340B program, we have a relationship where patients are given much discounted medications through a 340B formulary that we have through the federal government.
So one of the things I will add as Dr. Green is progressing the slides is that, again, the distinguishing attribute of community health centers is that, as we've described in the intro, that we do take care of patients that come to us with a lot of risk factors, a lot of challenges. And so the distinction for us, though, is that even though we receive patients who come to us with many, many challenges and that have had a lot of health issues in their lives. This model that we have essentially is a model that's an evidence-based model, and that regardless of the condition that the patient is in, that they come to us in, we are able to make an impact. And so that's one of the things, one of the real takeaways that I would like for everybody to have, that we really do make a difference in the lives of these people. And Dr. Green will proceed on in terms of talking about those measures that we impact.
Yes, I agree. So yeah, with the impact, we are also able to quantify that impact so that we can, know where we are, where we need to be, where we need to go, and then inform various other, healthcare decisions for the patients. So now I indicated that EXCELth is a patient-centered medical home. So what exactly is that? I want to just kind of speak to some of the things, some of the items that drive the most important reforms in healthcare delivery as a patient-centered medical home. So, as a growing body of scientific evidence shows that PCMHs, that's patient-centered medical home, are saving money by reducing hospital and emergency room visits, mitigating health disparities. They are also improving patient outcomes. In other words, the PCMH can contribute to better quality of care, which in turn drives cost reductions through avoided hospitalizations and emergency room visits. Additionally, evidence demonstrates that the medical home inspires quality care and cultivates more engaging relationships between the patient and provider, and captures savings through expanded access and delivery options that are aligned with preferences of the payer and the provider's capability. And so now to the outcome. So when EXCELth uses certain health outcome and quality indicators to evaluate, how we're performing and how well we're implementing this patient-centered medical home model. And these indicators also inform key improvement decisions in terms of access workflows and many other issues that may become apparent. So these are all of the many of the indicators that we monitor monthly, weekly. We are always looking to see on a monthly basis, on a weekly basis, how are we performing with certain measures. And so you can see the list of measures, but I'm not going to go through all of them, but I did want to identify a few measures that I think are just to give you an idea of as a FQHC, how our efforts really drive up our numbers and in our quality improvement, from a quality improvement perspective, but also from a health outcomes perspective. So low birth weight. So if you see, this is pretty much a comparison between EXCELth. So where you see health center column, that's EXCELth's our performance. And then state, of course, that's Louisiana, and then national. So we're going to compare how we perform with national rates. And so for the low birth, I want to focus your attention on the low birth weight measure. And so we monitor this measure, and as you can see, we're at 0%. And now for this measure, this is it's only 2 measures whereby the lower you do, the better. And what this measure is we have to report this information to the federal government as well. So we're kind of we're held to these measures, and we're held to do a good job at ensuring that we have to perform at a high level in terms of providing quality care to our patients. And so this measure is how many children who were born, who received prenatal care at EXCELth in any given year. In this particular year is 2019. So in 2019, of the patients who were provided prenatal care at our health facility, how many of them were low birth weight? So it's the mothers, of course, of the mothers who received prenatal care. How many babies were born of low birth weight? And I am proud to say that none of our babies in 2019 were low birth weight. But if I have you go further to the right, you see that the state average is typically 12%, and then the national average is 8%. So we're doing better in that regard. And so again, we're following this. And anytime we see any deviation or any increase where we shouldn't see any increase or decrease, that's where we have to step back and say, okay, what's going wrong? What do we need to improve? And again, that's all under this patient-centered medical home concept. And so that's our Bible. And so I'll jump next to the colorectal cancer screening measure, which I'm most proud of. And reason being is because this is one of those key care coordination indicators that reflects how we're performing, and it allows us to evaluate ourselves in terms of how we're performing and coordinating care for patients. So with we don't do, other than there's a certain in-house screening you can do for patients, but other than that, we do not provide colorectal cancer screening. So we very often refer our patients out to community, other agencies like UMC, LSU, or other entities that actually conducts the colorectal cancer screenings. Now, it's not just making an appointment for a patient, it's ensuring the patient can get there, it's ensuring that there aren't any access barriers to the patient, and engaging this treatment, and then ensuring that we receive the information back on this colorectal cancer screening. So it's very dynamic in terms of there are multiple pieces in order to ensure that each patient receives their colorectal cancer screening. So our measure is at 84%, and we're almost double that of the state, who's at 41%, and then the national average is at about 46%. So we're most proud of that. And there's just a lot of efforts we've been taking in monitoring and ensuring, now giving alerts to ensure that providers on a monthly basis are aware of where they are with their patients who qualify for these services. And those are patients between the ages of 50 and 75. And then I'll jump quickly to HIV. This measures of all the patients we identified who are HIV positive, who receive the proper linkage to care. That's a measure that they hold us very, very, they're very serious about this measure, and we've at 100%. So 100% of the patients that we identified, we were able to link them to care. And state averages it was 89%, national average is 87. And so for the sake of time, I'm going to jump, but I think you get the gist here. So I'm going to jump to the next slide. And then another performance that I'd like to talk about, a performance measure that we really we hold very important to the PHCMH model, is potentially preventable admissions, and this goes to costs. And so we call them PPAs. So PPAs are admissions to hospitals or long-term facilities that could reasonably be prevented if care and treatment was provided according to the accepted standard of care at the primary care level. And so the occurrence of a high rate of potentially preventable admissions represent a failure of the primary care provider and of the PCH model provided to the patient. This is how we impact costs, because care which happens at the hospital is much more expensive than happening at the primary care level. And so I provide you this table that's embossed in orange just to show you how our rates are looking thus far. So I give you the first column that says baseline. And this is just to see over time what our performance is looking, comparing two different segments of time. And so for the calendar year 2028, so there's an algorithm that's generated, but whereby we have what our actual preventative patient admissions, potentially preventable admissions were, and then what our expected admissions are, and that's a ratio. And what the whole idea is, we want to get closer to zero. Anything that's closer to 1 or above 1 is concerning, and that is because, and I'll give you the example right below, and that is if you see, so we were expected to see have 100 potentially preventable hospital admissions, and this is in calendar year 2018. But we in fact had 109, and so that gave us a 1.09% ratio in terms of preventative PPA ratio is what it's called. Now, that is, again, we performed, we did worse than what they expected us to do. So what do? We take in efforts to ensure that we're getting patients in. If they missed appointments, we're getting them in. Most of the time, the preventable visits, the admissions are things that we could have handled at the primary care level. Again, hence saving money. And so this is then in the year of subsequent time frame, you see we actually improve greatly to 0.69 ratio. And what that is essentially, we were expected to have 100 preventable, potentially preventable visits, and we actually had 69. And so I'll bring your attention to the top right of the screen, and we actually did receive a gold tier. We achieved gold tier, and that's we improved by more than 15% in that measure. We were set to improve just at a 93%. I'm sorry, 0.93%, and we actually improved to 0.69%. And so that just speaks to, and I'm going to put my pointer on so you can see where I am. That just speaks to our efforts. And once we get data and the data shows us our performance, we jump in and we, if we have to go to the drawing board and figure out what's the workflow or the best healthcare decision that we can make in terms of improving these numbers, we are very responsive here. And again, that's one of those key elements to patient-centered medical homes. And so I will say, with all of what you saw, what I provided in terms of data, we were recognized, and as you know, we're able to see with the 2 slides before, with our outcome measures being as high as they were in comparison to the state and to the national averages, we this year and last year and the year before, and we continue to, should I say, receive from HRSA, we received the Health Center Quality Elite Award. And what that is that we were basically recognized that by HRSA again, and for our performance, and we were measured against about 1,400 other community health centers nationally, and this recognition ranks us among the top 10 of health centers for overall clinical performance. So for those who have been with us, for many years, they're able to appreciate the growth and our ongoing achievement of this award. And now our goal is, there's a award right above this where you're in top 3%. That's our next goal. And we're working towards that. And I'm very hopeful that we would achieve that goal. So now, what other attributes that distinguishes EXCELth and other community health centers from others? So at this time, I just want to show you some, in terms of mitigating health disparities. There's some key factors in mitigating health disparities that does allow, that does afford EXCELth an opportunity to be distinguishable, and other health centers to be very distinguished in terms of what we do for our patients. We're not just providing care, we're actually, we do food drives. We call them Food Fridays. And so throughout the pandemic, we identified and are able to understand that there are food security issues, and we have to provide these items. We have provided these items throughout the pandemic. So what really is important about this is that this encourages and cultivates community engagement, patient engagement, and it cultivates the relationship between the healthcare provider, the health center, as well as the patient. And all of this is an effort to mitigate health disparities by providing nutritious food. And so here are just some other opportunities where just families and who were incredibly grateful to what we provide. And so we do a lot of collecting for such opportunities to provide families in need of these services, of these resources that they may not have. And some of these people on these patients that you see, they were actually Hurricane Laura survivors, or victims, if you will. And so then this slide here, it's a little blurry, but I thought it was important to show that there was a really large event for Hurricane Laura victims at the New Orleans Convention Center. And so as a true EXCELth fashion, we set up shop there, and we were able to acquire a large amount of donations. And so we were available to the community, and we were able to give out all the donations. These are just some of our workers who had transported the donations, and here's what we were able to provide. And in these bags, there's all kinds of things, but you can see this very good and valuable things that could really come in handy for someone evacuating from the hurricane. And these are just some other people engaging our services and donations. And
Dr.
so,
Green?
yes.
Hi, this is Gabriel. I had a question, especially with you talking about COVID. Do you guys, are y'all looking at or sort of contemplating what's the next step with COVID as far as expansion, a change in some of the needs that you're seeing? Are there some trends you guys are looking towards, as you move forward into 2021 and on, just based on the latest, disasters that have sort of come online? And I mean, is that changing, how you guys are deciding to expand, or how you're operating currently, thinking about partnerships, things like that, strategically planning for the future?
Yeah, so great question. So I'm going to jump to what we've done so far in terms of considerations of COVID and expanding. And I'm not sure if you're aware or not, but we have a very, very expansive COVID testing system where we, at each of our health centers, we do drive-up testing for non-patients. And of course, we're testing our patients, but we also use, in the next slide, I'm eager to show you that, we also have actual outreach staff that are in place to identify patients who may have had employment issues as a result of COVID. And we also have partnerships in place, and I let Dr. Webb speak more to that. She can articulate more of the partnerships that we have in place in terms of COVID and understanding whether the needs or what have you. But yeah, we are very much so, in play with our partnerships with even other healthcare agencies that we work with to organize what they may be donating and contributing to the community compared to what we may be contributing to community. We gain clothing from different entities for those who may be in need of clothing. And we just run the gamut really. But Dr. Webb, do you have more to say to that?
Yeah, I would just say I would just say to the question in terms of how has it impacted our future planning, and it has impacted it very significantly in that, you know, we have to really reevaluate and look at the way that we deliver care. So we are again very concerned about this second wave that we see going across the country, and so we are again monitoring that very closely in terms of our protocols. We have essentially established our own stockpile of PPE in the event that this wave does occur. We've had to make modifications to our facilities in terms of structurally, with this idea of an open concept of functioning to basically putting plexiglass in place. We've had to convert a significant number of our services to telehealth. We are now kind of reverting now back, but we will basically continue to provide telehealth services. As far as design, in terms of any facilities that we look at going forward, we will certainly have to consider what we've had to deal with as far as this pandemic in terms of the design, because what we've had to do is go back and restructure everything in terms of to provide protection to patients and all. And that's just a few things.
Okay, and so next, I'll let Dr. Webb speak to this slide, but we were featured in an article, and this is, and so I'm gonna hand this off to Dr. Webb.
Yeah, okay, so this is, again, we're helping you to understand the ways in which community health centers serve our communities. So this happens to be, well, it started off as a photograph. The child that you see in the picture came to us, her and her mom came to us for services to see our pediatrician, Dr. King. And so she shared with Dr. King that it was her birthday, and her mother had gotten laid off because of the COVID pandemic. And so hearing this information, the staff rallied around this whole notion, gathered up a whole bunch of stuff, and the next day had a birthday party for this child. And again, this is just an example of the kinds of things that community health centers do. I happened to be interviewed for this article and talk with the person who essentially interviewed me, and so we talked about these things. And so he asked if I had in terms of a photograph, and I shared this photograph, and so we ended up being featured, in this article. But again, this is just an illustration of the kind of work that community health centers do.
Mm-hmm. And to Miriam's question, there's a blurb in this article that I think it really does highlight exactly that it really does support it, community health centers, what our missions are and what are some of our key objectives. And so it says that medically underserved areas, including rural regions and populations, including the poor, the homeless, and foreign-born, depend on community health centers for care. And that line is absolutely, it underscores everything that, most, if not all, that is important to community health centers. It's all, come as you are, and all are welcome. And then to Miriam's question, a key part of being a patient-centered medical home is being so culturally sensitive to and having culturally sensitive healthcare providers to consider our patients. And so we like to say that we do a lot of mitigating healthcare disparities by even the trainings that we provide our staff. As you can see, we have very diverse staff. We have a very diverse pool of patients. And we have people who are Middle Eastern, they're Arabic speakers. We have people who are from Haiti, they speak Creole, and we have providers and staff in place to translate and speak their language so that they can feel welcomed. And also we provide a lot of training to our staff. The LGBTQ the community is very important to us, and so we provide training for that. And then also we have translators available if there are other languages. We have a Vietnamese translation, but if there are other languages that we may not have available at the health center, we do have translators for those patients. But again, a big part of being a patient-centered medical home is being that home for not just American-born or English speakers, but all. And so that is really, really a key to who we are and the services we provide. And additionally, we are held and bound by providing a comprehensive care to holistic care to a diverse a target population by HRSA, by the federal government. And so we hold that very seriously to us, considering the issues that are facing a lot of the communities who are experiencing health disparities and health inequities.
Okay, so in terms of wrapping up, we want to tie this back into, the whole notion of sustainable development in communities. And so one of the things in terms of, looking at the United Nations, in terms of, the 17 goals that's established for sustainable development and communities and cities, we again pulled out several that we thought had implications for us. In terms of poverty reduction, which is the first goal, we basically work with a population that's impacted by poverty. And so again, the work that we do confronts this issue every day. In addition to that, we are a provider of services and we hire people. We essentially have done this for over 30 years in this community, almost 30 years. Good health and well-being is goal number 3. And again, that's what we're all about. Decent work and economic growth, that basically is goal number 8. And again, we essentially feel that we've contributed over the years. We employ about 120 people. We're not a real large organization, but again, that 120 people employed consistently over a period of 30 years, it has made an impact on the community. Reduction of inequities, we've talked about that, how we address health disparities and how we basically, start off with the raw product that people come to us with a lot of issues and all, but we are able to make an impact on their lives and improve health outcomes. Sustainable communities and cities, in terms of that for communities to be sustainable, they have to have services, the services that we provide. Partnerships is another one. That's the 17th goal. And we do partner with a number of agencies across this community to accomplish the work that we have to accomplish in terms of providing care for patients.
And so everything we presented during this presentation, it really does tie back into the core elements of what a community health center is and what a patient-centered medical home is. And so with that being said, EXCELth, we provide, as a community health center, we provide care that improves health outcomes, and it's been proven through our quality indicators, our health outcome indicators, that foster better relationships with patients and healthcare providers, and then we mitigate health disparities and inequities, as seen. All of this can be quantified with our health indicators and quality indicators. We address social determinants of health. We provide high quality health care based on our quality scores. We increase access to healthcare and other resources, as you've seen. We do a lot of community partnerships. We do a lot of health fairs, and actually that's what we would consider the convention center. It's one of those health fairs, and that's just one of many that we do in partnership with other agencies to provide access and to healthcare and resources for patients. And then we focus on sustainability, and sustainability is an umbrella term for so much under the healthcare spectrum that I'm sure you can appreciate by now. But it can be patient engagement, It can be, it is patient engagement, as well as finances, as well as gaining buy-in and the community relationships and partnerships. And so, all of these factors really, truly do speak to who we are as a community health center, who is a federally qualified health center, who will continue to and focus on the provision of high quality care to our patients. Any questions? Any more questions?
We did have a couple questions come into the chat box. One of them was for the social determinants of health, have you seen an evolution of them over the last 30 years? And then the second question that we received was, what is EXCELth's funding source, and how do you cover the cost of building and maintaining your centers?
Okay, I think Ann asked, and I sent her a little note back. She just sent the note saying she had to leave, so maybe someone can share with her. But again, let me just take the one on the health disparities, rather the social determinants of health. Have we seen them get better or worse over years or whatever? So I would start off with, in terms of health disparities and those disparate conditions that people have had over the years. As a result of modern technology and really being able to provide services to people, provide services and meet people where they are in communities such as we do, we have had the wonderful opportunity to see over the years health outcomes improve. Much to have to do with early detection, preventive services, screening, and much of the work that community health centers do. In terms of the whole issue of social determinants of health, social determinants of health is somewhat of a more modern concept. Again, going back many, many years when we were dealing with health disparities, there was not necessarily the recognition that persons who presented with poor health outcomes could also be impacted by these other social determinants, such as racism, such as poverty, such as social isolation. So again, the social determinants are really, and it's wonderful that we do recognize them, because it helps us to understand the complexities and to find solutions to problems that we're addressing, and to appreciate them from the much more complex nature that they exist in. Again, many years ago, you treated the person, you treated the symptom, you treated the disease, and the person went back to these situations that you could not necessarily address. In many instances, we're not able to address them now because we do have limitations, but at least we recognize the impact that the social determinants have on people and put forth efforts to address them. Dr. Green, you want to take the second one?
Sure. And in regards to funding sources, so we receive a significant amount of our funding source from the federal government, from HRSA, and that's and so that they, under the 330 grant that Dr. Webb mentioned earlier, and that pretty much pays a lot of our salaries, if you will, and those kind of costs. But then we also get reimbursements, but from insurance, from insurance and claims. So for our insured patients and our publicly insured and privately insured patients, we submit claims and we gain monies from those claims. And so a big part of sustainability is ensuring that our revenue cycle management system is robust enough to where we're billing for the actual care that we provide our patients. And then what I do love and enjoy talking about is we also get gain income from a lot of our incentive payments and pay for performance as you can see with the quality indicators that we received. We even received this year with the award, we received about $100,000 in a bonus payment to the company regarding, because of how well we performed and being in the top 10% of community health centers. And in addition to that, insurance companies, because it's cost savings, it's a cost savings model and pay for performance. And so, the whole idea is we how much money, how much cost did we save in providing care at the primary care level, and whatever that cost per patient, there's algorithms that they have developed. Whatever that money's is that we saved, the money that we actually saved, we split that and share. It's a cost sharing concept. So we get some of that money, and then the health center, I'm sorry, the insurance companies, they keep some of that, they keep the rest of it, and we're able to finance ourselves and sustain in that manner.
We also, to add, we also get we get state funding, we get private foundation funding. So we have we have multiple funding streams that we basically exist on. The other part of the question had to do with how do we pay for buildings and operating costs. The federal government gives us part of our operating costs and all. However, though, in terms of buildings that we operate in, we, in most instances, have to raise the capital to fund those operations and do capital projects to essentially to fund, even in terms of buildings that we're in that we don't own, that we're building out into a health center.
Any more questions?
Dr. Celia, this is Miriam again. I don't have a question. I just wanted to let you know that it's been over a decade that I think we work together on your New Orleans East facility. Yes, and right. To this day, that has been the most rewarding and heartfelt project that I ever worked on.
Oh, well, thank you, Miriam. Yeah, we really had, that was a really great project, and we worked very hard on that. So we appreciate all of the work that you all did, and we'll consider y'all forever our partner in this. Yes. So thank you so much for that.
No, my pleasure.
Well, I think probably a thank you, Dr. Green and Dr. Webb. That was really fabulous. Thank you very much for coming and shedding some light on EXCELth for us.
Thank you for having us.
Okay, yeah, thanks a lot for inviting us.
Thank you, ladies.
Yeah, thank you. Thanks, thank you, Gabriel, for the referral. And it was so wonderful to see you, Miriam. We're gonna have to touch bases here.
Yes, we love to. We love to. Okay. It's been quite a while.
It's been a while.
Thank you.
All right, thanks everybody. We do have an event on Thursday of next week. It's Wagner and Boss Water Retention. I think it's the Mirabeau, the Gentilly water management facility that they've been designing. So tune in 4:30 next Thursday.
Thank you.
Thanks everybody.
Bye.
Dr. Green and Dr. Sheila. Bye.
Bye.
Bye-bye.